I'm fairly certain that some or all of you have at some point observed that you're not adequately paid for preventing future illness. I'm not paid sufficiently for preventing an illness from occurring in the future. I am fairly certain that some or all of you at some point have observed or opined I should be paid more than others if I deliver a better clinical outcome than others. I deliver a better outcome, my compensation should reflect that. Granted, let's grant that. Over what measurement period would you choose to be evaluated for those parameters? Would you choose to have your ability to prevent an illness in the future measured over a 1-year time period, a 5-year time period, a 10-year time period? How would you choose to have your ability to differentially produce a better outcome than your peers be measured? Would you choose that in a 1-year, 5-year, 10-year time frame? My guess is very few of you would choose a 1-year measurement period. You'd be a little more comfortable with the 5-year measurement period. And we'd all probably get some consensus around, give me a decade and measure me on my ability to avoid future illness and to produce a better outcome than the broader set of my peers. And you'd be pretty comfortable with a level playing field on that. The conundrum then is, what is the performance measurement period for a payer? I think you already know the answer. It's 12 months. Every 12 months, the slate is wiped clean, premiums are reset, populations migrate in or out in regard to who is insured, and we start from scratch. It's a 12-month race, over and over and over again. The payers know that as it comes to prevention, the return on investment for primary prevention, preventing the occurrence of an illness, a disease, is 3 years or longer. In other words, the increased costs of visits, pharmaceuticals, laboratory monitoring, et cetera, 3 years or longer for a return on that investment. They know that in a secondary prevention mode, the prevention of the manifestation of a disease, that 2 years or longer are usually necessary to get the return on that investment. And they know that for tertiary prevention, the avoidance of comorbidities associated with a symptomatic disease, the return on investment there is current, less than a year. They're really comfortable with tertiary prevention investments. They're fairly comfortable with secondary prevention, and they're struggling with understanding how they can produce a sustainable financial model on a 12-month measurement period that encompasses the primary prevention that you all, I, and every payer knows is critical to success. That, in essence, is the challenge that exists today for payers seeking to reimburse for the types of services that have been discussed here today. I have a box warning for this session, and that is I have been asked to represent all the payers for whom we provide services. There's some 300 payers that we provide services for, and I've been asked to represent them. And I will do so, which means that some, but not all, that I have to say I agree with. So that is my box warning. I'm mostly worried about whether people will sit with me at lunch today and by lunch table. I got the short straw. Dr. Penn gets to represent physicians, Dr. Lepke gets to represent employers, and I'm stuck with payers. Please be my friend. So I should then qualify myself for the ability to adequately and accurately represent payers. Jake mentioned some of our market footprint. Optum is a good-sized business that you likely never heard of. We are the fun part of United Health Group. We represent about 1/4 to 1/3 of that company, and I'm very proud that we are able to provide technology, consulting, and services to many consumers, to many hospitals, about 5,000 out of the 6,600 hospitals in the U.S. About a quarter of the 880,000 physicians in the U.S. use some of our services or technology today. And many of you probably use it and don't even realize that it comes from Optum, and also many life sciences clients. For the most part today, I'm going to reflect the thinking of the 300-odd payers that we represent. And those are the large national insurers, Humana, United Healthcare, Aetna, Cigna, all clients of ours, and the local Blue Cross and those regional insurers as well. Not-for-profit, for-profit, large and small, all of them. The black box includes a warning that says, I will not disproportionately represent any one insurer. So I will use the comments to reflect all of them. How then do payers think about resolving the conundrum that you seek reimbursement around activities that are measurable over multiple year periods, and they must run a business on a one-year basis? One aspect of that would be to change the the funding of healthcare. And Dr. Lepke talked a lot about self-funded large employers. And indeed, the self-funded large employer is an example of someone who can look over multiple time periods when they have a workforce that is relatively stable, not a lot of turnover. They have pre-Medicare employees, for example, who they are providing health care for. They can afford to look over longer time periods. But the reality is, in the fully insured market, which still is the vast majority of the healthcare benefits administration and funding in the U.S. today, that 12-year time period remains very important. It may be increasingly important as some large employers begin to move their membership away from their own self-funded plans and into private exchange, fully insured products. What I would like to describe today then is the journey that some physician groups, some hospital organizations, some integrated delivery systems are taking in concert with plan sponsors, insurers, and CMS for Medicare, and what types of observations are coming out of those early experiences. And I have good news. There are really positive things happening. I have bad news as well. They're happening in small segments of the United States, and alone these activities cannot change the overall accountability of the healthcare marketplace in the U.S. I'm showing you a journey. The journey is one that seems to resonate amongst the organizations that we provide services to. That movement from your left hand of going from a fee-for-service world to your right hand to being compensated for producing better patient satisfaction, better clinical outcomes, and greater affordability for the broad population. This is a journey that 350-odd healthcare provider organizations were on last year through various accountable care organizations. And this year, or in 2014, I should say, probably around 500 different organizations will be on this journey. The data shows from the early observations amongst these participants in new reimbursement models that they can consistently improve objective quality measures in one-year time periods, and that they can mitigate medical inflation in those populations by almost half. That's a CMS Medicare beneficiary observation. Reducing medical trend by half, consistently improving quality and objective measures. That's the good news. How did those 350-odd organizations move toward that outcome, deliver the kind of prevention that's being talked about throughout today and tomorrow and being demonstrated out in the halls here today? And how did they do that in a manner that was financially sustainable? That is, in essence, the offering that comes from the concept of accountable care organizations that many payers are seeking to embrace. For a provider organization to be successful in embracing a reimbursement arrangement with a commercial payer that has a value-based component to it, that is, that at the end of the measurement period, there may be a share of the gain or a share of the loss attributed back to the participating physician or hospital, that success requires attention to the left-hand side of this journey. And although we're going to spend most of this short session with the right-hand side of this, I don't want to fail to mention that the generation of new capital by these organizations is critical to success. They must find some ways to create some newfound money to invest in the infrastructure, the technology, the process change, and the new people that will be necessary at scale to produce the kinds of improved clinical outcomes and greater affordability that will be required to be successful in these new reimbursement models. This is the concept of accountable care as the payers who I serve every day think of it. I'm going to spend some time in the three domains of this journey: generating new capital, care delivery model change, and investing in new capital. And I'll just hit just for a moment on the generating new capital piece. Hospital, physician groups, integrated delivery systems are focused on generating some additional capital outside of their operations that they can use then to prepare themselves to embrace new reimbursement models that will allow them to be successful when they do prevent an illness or disease from occurring at some future point, when they do produce a better clinical outcome than their peer across town. They're looking at ways to improve patient access, improve clinical care process flow, manage medical necessity burdens that come from both commercial payers as well as CMS, improve their coding, and improve the throughput of dollars associated with their reimbursement. Basic block and tackling. And what we're finding is larger systems of care are taking about a third or so of that new generated capital and then investing it into the additional people, new resources, new technology that is then necessary to, at scale, embrace new contracts that will allow them then to continue forth in the prevention of disease, in primary prevention, and in producing a differentially greater quality outcome and be adequately, indeed competitively, reimbursed for that. Let me then move to the center aspect of this journey that payers and those physician and hospital organizations who are embracing these value-based contracts are on, and that is the care delivery model, the preparing for change. What's necessary for a physician or hospital organization to be compensated for the types of outcomes that we just talked about? Well, I would argue that transformation requires moving from an activity-based measurement to an outcomes-based measurement. It requires transforming from a facility-based care process to a community-based care process. And that transformation requires moving from a payer-centric risk management strategy to a provider-centric risk management strategy. Moving from activity-based to outcomes-based measurement, moving from facility-based to a community-based care process, and then transforming from having risk managed primarily by the payer to risk managed, at least in part, by the provider. These three areas of transformation are critical in this area of preparing for change and care delivery transition, and these are the areas that commercial payers and CMS are working on right now. CMS, for example, has 32 pioneer ACOs, and they'll have about 400 or so Medicare shared savings participants in 2014, each of whom has transitioned through this journey and is now at the far right-hand side, and early results would suggest that they are, in general, quite successful. They would like to see more gain share than they're getting right now as a group, and they will as the years proceed, no doubt. The care delivery model transition that's so important. When you generate some new capital, you're preparing to invest that capital in some new capabilities, but you also must reform your organization to think in terms of a value-based reimbursement model. Requires several activities. It requires building a consensus, an agreement on the goal. It requires building governance, accountability for the goal, and it requires building structure, alignment to the goal. And in this area, I would suggest to you that there's three things that are really, really critical here that we've observed as we've watched peers of yours around the country embrace these new reimbursement models. And the first is that there be extremely visible and extremely spirited physician leadership. Secondly, there must be very substantive IT leadership engagement. The technology investment and the technology strategies necessary for success at scale in these new models is very significant. And third, and perhaps the attribute that is most often missed as physician groups enter into these models is you must be a learning organization. You must be a continuous quality improvement organization. Hurdles for meeting quality standards to achieve gain share in value-based contracting move year to year. They become increasingly aggressive in each subsequent year of a contract. Every payer currently putting out value-based contracts in most every market in the country includes quality measures that require a minimum level performance to achieve a gain share, and those quality measures go up, become more difficult with each subsequent year. Therefore, you as an organization must also have the mindset that says we must learn, continuously learn, we must invest in the learning, we must disseminate that back into our organization, and we must reflect that in changes to process that are performed consistently across every clinician in the organization. Let me then go to the third area, the final area of the journey from moving from a fee-for-service world to a value-based contracting world. And this is the area that tends to get the most focus, but I would argue to you that the hardest part of all of this is the first and second phase. And while the world of lay press talks often about accountable care organizations, it appears that there's dozens launching every single day. The reality is what those represent are provider organizations, hospitals, or physician groups who are embracing a value-based contract by a payer in a market. But to truly become an accountable care organization requires re-engineering of structure, new people doing new work, and new technology being not only implemented, but adopted. So the last area I want to focus on is this investment of the new capital, and I'll divide that into two types of capabilities in the technology domain. The first is financial and clinical analytics. That is the ability to predict the medical experience of both individual health consumers and defined populations, to predict the future medical experience of individuals as well as any defined population. And then also population health management technology. That is the technology necessary to identify, to engage, and then to impact every individual within a defined population who has a health need. Those are the core technical capabilities necessary to be successful in large scale in any value-based contract coming forth from any of the payers whom we serve. Within those two domains of work, then, let me suggest that those new capabilities fit amongst some legacy technical capabilities. The electronic medical record, of course, is a core functionality that is assumed when I mention these two new technical areas for investment. I think of the electronic medical record as a physician-centric record keeper. The EMR is effective at keeping track of all the activities I perform as a physician. I think of health information exchanges as an ability to aggregate that physician-centric data across the community so that I get a record that is around the individual consumer. I've seen my PCP, my two specialists. I've had in a freestanding imaging center or MRI, and I've been to the ED and had one admission. The health information exchange should allow the aggregation of that data around me so that I now have a medical personality for me. Our analytics then allow the analysis of all those individuals to predict the future medical experiences of those populations and those individuals. And last, the population health management technology allows willing and interested clinicians, you, me, other clinical individuals or administrative individuals who might work for us to make a well-meaning outreach, to engage an individual who's making poor health decisions or having poor health outcomes, and to impact them, bring them to the office, or engage them telephonically or by other means. These are the areas that are necessary to have in place to be successful in value-based reimbursement models. Payers know one other thing that is often a surprise, probably not to this room, but if I had instead a room full of hospital executives, first of all, it wouldn't be near as much fun. But secondly, they wouldn't know the data on this slide. And my suspicion is this is no big deal to you. Hospital executives think that if they run the best clinical line of service in their community, cardiac, ortho, cancer, they are good to go on any value-based contract that might offer a gain share for performance at a higher level. It's not true. The reality is, in a commercial population, this is the 5.5 million members for whom we provide case or disease management services for, and this is last year's data. This is commercial only, not Medicare. The vast majority of costs are attributable to chronic illness, 69%, as you can see. And at your right hand, the vast majority of costs are accrued in the ambulatory setting. Population medical costs are largely from the treatment of chronic diseases in the ambulatory setting. No aha here, right? It is a big aha for the hospital CEO who thinks that by having those clinical lines of service humming on the inpatient setting, they're going to be successful in a value-based contract. Your competencies, your experience, and those of your peers around the country are necessary for any organization to be successful long-term in a large-scale value-based contract. I'm going to finish with an observation from our provider groups who have been successful in value-based contracts. So this is a little bit more of a provider perspective, but it's a provider perspective that I have gained by sitting at the table beside the payer, working with interested large provider organizations and making sure that they're going to be successful when they sign that new reimbursement arrangement. Here's what those provider groups know. They know that to be successful in a value-based contract, I only have to do 4 things well. That's it. This is not rocket science at the end of the day. I have to be able to be intelligent about who, as a primary care physician, I refer my patients to for whom I have this value-based contract. If I know that these 2 orthopedic surgeons are appropriately conservative, have a lower redo rate on hip and knee replacements, have a lower cost, produce a better outcome, and my patients feel better about that experience, I will constrain my utilization of such specialists to those 2 individuals. And by the way, I may actually go out and get a service level agreement with those 2 orthopedic surgeons saying, you'll see my referrals within 24 hours, I'll have a report in 48. Secondly, these provider groups that have been successful know that they need to manage the patient from the moment they walk across the threshold of the hospital into the parking lot until the moment they come back into the physician's office for a follow-up appointment. From that, we know that we can drop readmit rates by about 40%. And by the way, on the network management piece, we can drop costs by 10 to 15% per episode of care. That's orthopedic, lumbar discectomy, hip or knee replacement. And we can drop redo rates by about a quarter by constraining who individuals are referred to in a value-based contract. Third, they know that there is no such thing as too much investment in in-home care for the highest acuity patient, that 1% that's the sickest. The 1% that got sent to a skilled nursing facility or sent into the home with very high intensity needs, lots of DME. They'll send physicians, nurses, telemedicine, nurse practitioners, all kinds of people into that home. And those physicians who have been successful here know that there is no such thing as investing too much in that group. And they will assign their own team of physicians to enter the home and take care of those folks. And then last, expanding chronic disease management. By that I mean, what these physicians have learned is, it is exactly the chronic disease patient you most need to see in a value-based contract who is the least likely to appear in your office? I think this probably resonates with you. The one that's non-compliant, the one that's complicated, the one that's got some social challenges, some behavioral health challenges. That's the one you need to see. Are they going to be there? No. But the challenge, and payers know this, is that the effort required by you and your staff to get that person into the office or to get them compliant or to overcome the comorbidities in their life are not compensated. In a value-based contract where there's a gain share at the end of the day, they will be compensated, and these physicians in these contracts now are investing substantially in telephonic outreach, engagement, even transportation, and community health service linkage for these individuals. I'll finish with just in the interest of time, and getting to the, just want to show you a photo of some of the technology. To finish, just to let you know that this is real. This is an image of one of those physician groups that has been successful in a value-based contract. This happens to be a Medicare Advantage contract with a commercial insurer for a group in, I think this is in Southern California, that has been very successful. And what they're doing here is they're using technology, using medical claims, electronic medical records data, laboratory results, and pharmacy feeds to identify those people who have the diagnosis of diabetes who are analyzed to be most at risk of admission in the next 3 months. So these are rank ordered. So I've made, these names are made up or changed, I hope, I think. I know they are. Annette Underwood, for example, who's 88 years old, is the most likely person in this value-based contract for this group of physicians to be admitted the next 3 months with a diagnosis of diabetes. And this team who works for this physician group can click right into a view program here, identify what programs they can deploy for her, and proactively prevent her from being admitted. This is exactly what we all wanted to be compensated for doing. Preventing an event in the future that we can't prove would have happened but for our activities. This, and I have many other screenshots as well I would invite you to look at. I know you have a copy of this information as well. This is an example of how payers are beginning to embrace, through value-based contracts, relationships with physicians that do compensate them, you, for the types of services that you want to be compensated for. Preventing an illness from occurring or disease from occurring that would have occurred but for your work. Compensating you variably for variable outcomes. Hopefully you're above average or you wouldn't be here. Those are the early changes in the payer marketplace. I would suggest to you, I'll leave with an optimistic note, that I don't know a single payer who we provide services for today who isn't interested in moving almost all their contracts, particularly with primary care physicians, to a value-based component where a gain share is provided. They want to fund primary and secondary prevention. They have to do it in a manner that allows them to be successful and sustainable when measured in 12-month increments. That's the conundrum in our healthcare delivery system. It's not solved, but I would argue we're well on our way to advancing that. Thank you very much.